Good evening, friends. At the outset, let me wish you a very, very happy Independence Day. We are on the eve of the 74th Independence Day.
Republic Day,
And,
sir.
sorry, the Republic Day. My apologies. And would like to take this opportunity to tell you guys that this is the venture which has been undertaken by the newly appointed CSI committee, and that is a journal club which is going to help many of the students as well as all of us to bring in some better aspects of the articles which are being published in the journal. And the whole idea is to discuss these particular articles verbatim and take the message home. We have today three very important articles. One is the outcome of PTCA in patients with Takayasu's arthritis. The second is mevacaptan in adults with symptomatic obstructive hypertrophic cardiomyopathy, which is a very, very hot topic. And the third one is related to the valvular heart disease, shifting focus mainly to the myocardium. Let me also acknowledge that the effort for this particular journal club is entirely credited to Milind, and he has done a great job with the type of topics which he has undertaken. And without wasting much time, I think I'll let it go forward and Milind take it over. Thank you. Milind, you can start.
Okay. Thank you. Good evening, everybody. I'm not going to take much time. We are on a very tight schedule as it is because we have been able to incorporate 3 articles in this journal class. And we have tried to select diverse articles from across the spectrum of cardiology, as Sir said. And the format is that first the article will be presented. We will have a video presentation. And then after that, there will be 2 experts who will give their thoughts on the article in about 5 minutes. And then there will be a panel of 3 panelists who will then further discuss this article and give some take-home messages. And if the attendees have any questions, please feel free to type them in the chat box. Some of the important questions maybe we can take up for the discussion if time permits. So we have 3 articles. The first is an original article. The second is a drug trial, which will excite quite a lot of discussion, I think. And the third is a review article, as Sir said. So without much ado, I think I'll hand it over to the Lupin technical team and ask them to play the first article.
Good evening, everybody. I'm Dr. Siddhant Yadav, and today I'll be discussing with you the study on percutaneous interventions in patients of Takayasu's arthritis. The study was done by Dr. George Joseph and his colleagues at CMC Vellore, and it included over 1,000 patients over the span of 25 years with rigorous follow-up. So let's dive right into it. Takayasu's arthritis, as we all know, is a granulomatous disease of the large vessels. Current guidelines for treatment of these patients shy away basically from percutaneous interventions unless it is a life-threatening situation or an organ-threatening situation. This is generally believed to be the case because it's believed that these patients have a lot of collaterals already developed and that percutaneous interventions could lead to more complications. And therefore, the focus has primarily been mostly on immunosuppressive medications. So all the patients in the study met either the American College of Rheumatology criteria or the Ishikawa criteria, or both of the criteria for Takayasu's arthritis. They underwent a full workup at the beginning, including a CT scan for diagnosis. In cases where tuberculosis was suspected, quantiferon TB gold tests and HRCT thorax tests were done. All the patients were on immunosuppressants, including steroids, which were tapered over a period of 6 weeks to maintenance doses. Mycophenolate mofetil was used as a second-line immunosuppressant, and tocilizumab was used in cases of refractory disease or in cases where we needed rapid control. So this is just a slide to enumerate all the specifics of the American College of Rheumatology criteria and the Ishikawa criteria for Takayasu's arthritis. The need for percutaneous interventions in this study was determined on the basis of symptomatology on whether the patients had hypertension or pulmonary hypertension, on if the pressure gradient across the stenosis was significant or if the stenosis was more than 70%. So these patients were taken up for interventions. In cases of aneurysms, again, symptomatology played a role, as well as the size of the aneurysm, and if the lesions posed a significant or clear risk of future complications, they were taken up for interventions. Active disease was determined on the basis of a mix of clinical and imaging findings, as well as lab parameters such as ESR being more than 20 or CRP being more than 6. The study included more than 1,000 patients, with 942 undergoing percutaneous interventions, around 200 receiving only medical management, and around 100 received surgical therapy. The authors recognized the heavy lean towards intervention in their study and recognized that that may be due to their center being the referral center in their region for Takayasu's arthritis. Therefore, they likely receive the more advanced cases of Takayasu's arthritis. In cases of successful percutaneous interventions, a follow-up was obtained by angiography at 6 months. A USG was advised yearly, and either a conventional or a CT angiography was done at 2, 5, and 10-year intervals. The early outcome of the surgery was assessed immediately after the surgery, and the late outcomes were assessed at least 3 months after the procedure. All the patients receiving interventions were kept on aspirin indefinitely, with an added clopidogrel for 3 months for bare or covered stents and for 12 months in cases of drug-eluting stents. So here's a slide showing the artery-wise distribution of the percutaneous interventions done in this study. Unsurprisingly, subclavian and axillary making up the largest number of interventions done. The point to notice is the multiple number of interventions needed for each lesion, with an average of 1.5 interventions per lesion, and some even requiring up to 7 over the period of the study. The authors of this study noted an incremental benefit in repeat procedures in their patients. For example, after the first procedure, the late success rate hovered at around 50%, but by the time of the fourth intervention, the late success rate or the cumulative success rate was up to around 83%. The authors noted an increase in success rate of 23%, 7%, 3%, and 2% in repeat interventions after the second one, which shows the progressively smaller numbers of patients coming back with restenosis, as well as the higher chance of repeat interventions required after the second intervention. However, all the re-interventions showed high rates of success, technical success, and low rates of complications. Regarding the strategy of interventions in these patients, direct stenting had the best results. However, the authors recognized that this data may be skewed because around 43% of these direct stentings were done in aortic lesions. Amongst the other strategies, just primary balloon angioplasty in patients which did not require stenting had good results with lower repeat interventions. And in cases of complications after balloon interventions, stenting were required. The long-term results were good, but there were repeat interventions which were required in these patients. The best results obtained in the study were from covered stents. These were mainly used in aortic disease and aortoosteal lesions. The authors noted that this may also be due to the fact that covered stents allowed the operators to go at higher pressures. The restenosis seen in covered stents were generally edge restenosis, while those in bare stents were diffuse restenosis. Self-expanding stents gave good short-term results. However, on the long term, they required multiple reinterventions. In cases of smaller arteries, drug-eluting stents gave comparable results to bare stents. However, these were applied at different types of lesions, so they cannot directly be compared. Interventions in aortic disease gave rise to the best results with a 97% success rate, which was followed closely by iliac disease. The lowest success rates were obtained in coronary disease and subclavian disease. The iliac artery showed the highest rates of rupture, while numerically it was most often seen in subclavian arteries. These were highest in cases where there were total occlusions. Renal arteries and mesenteric arteries needed covered stents the most. There were cases of cerebral hyperperfusion, which was an important complication seen in patients mainly who had diffuse disease of the aortic arch branches. This necessitated multiple reinterventions with gentle graded dilatations, which gave good results on the long term for carotid disease as well. Percutaneous coronary interventions gave rise to good short-term results. However, in the long run, the success rate was only about 75%, which leads the authors to suggest that in cases of reocclusions in coronary artery disease, the patients may be better served with surgery. Subclavian disease also had a relatively low late success rate. However, there was good success in patients who had smaller lesions of less than 8 centimeters. Here we can see a bald aortic arch on our left in panel A, which was opened up with interventional techniques in panel B, and panel C shows robust results lasting at 4-year follow-up. Disease activity is found to be a strong indicator of restenosis the first time. However, after the first reintervention, disease activity is found to be a negligible contributor to repeat interventions. That tells us that lesions that have stenosed one time are likely to stenose again, regardless of the disease activity of the patient. Long lesions and isolated arch disease were related to more restenosis, and patients with aortic lesions and patients in which covered stents were used had good rates of restenosis. Around 6% of the patients in the study were previously treated for tuberculosis. However, the authors consider a mix-up in the diagnosis between tuberculosis and Takayasu's arthritis in this study to be negligible because they found no flare-ups even though all the patients were on immunosuppressive medications and the patients all fulfilled the criteria for diagnosis of Takayasu's arthritis. Patients with aneurysms and dissections who underwent percutaneous interventions showed very good early and late results. Most of the cases of restenosis were edge restenosis and were seen in patients in which chimney techniques or fenestrated stents were used. Angiographic surveillance was advised for such patients, and tight control of disease activity was also advised for them. The restenosis rates after percutaneous interventions were found to be higher than occlusion rates of bypass grafts in Takayasu's arthritis. However, after reinterventions, the percutaneous intervention success rate rose to about 83%, which was higher than the patency rates of bypass grafts. Moreover, the repeat percutaneous interventions were simpler and had fewer complications, about 6 times lower than the first intervention. So the authors suggest that percutaneous intervention could be advised to patients of Takayasu's arthritis potentially as a multi-stage procedure with a 50% chance of additional interventions being required. After the second intervention, however, the third intervention and the fourth intervention have higher rates of restenosis, so that could be individualized to particular cases. Open surgery played a complementary role to interventional procedures in this study. The need for open surgery kept on decreasing over the period of years as the percutaneous interventional techniques kept evolving. However, cardiac surgery, ascending aortic surgery, valvular surgery, coronary artery bypass graft surgery kept on increasing over the years as the number of patients increased. Here's a graph showing the same thing. As other open surgeries kept on decreasing, the percentages, or rather the numbers of cardiac surgery and proximal aortic surgeries kept on increasing over the years. The authors noted a 1.5% procedure-related mortality in their study, which compares favorably to other meta-analyses. These contributed to around one-third of the total deaths in their patients, with 60% of them being due to IC bleeds, commonly due to cerebral hypoperfusion, which occurred while treating bald aortic arches or diffuse aortic arch branch disease. 28% of the neurological events occurred due to subclavian artery interventions. Subclavian artery interventions also had the highest rates of re-occlusions or stent thrombosis with a 6.8% rate at 72 hours. This occurred most commonly while treating total occlusions. Iliac arteries had the highest rates of rupture, while the highest number of ruptures occurred in subclavian artery disease. The authors also noted that while treating restenotic cases, the usage of shorter balloons led to more distal embolizations from the intima, which led them to use longer balloons in the later part of the study. Stent-related complications like dissections were treated easily and were minor in their study. As compared to balloon angioplasty, stenting led to higher rates of restenosis in their study. However, the authors suggest that this may be due to the fact that whenever balloon angioplasty ran into complications, these patients had to be stented. Elective stenting with predilation, where the lesions were unselected, required fewer rates of reinterventions as compared to adjunctive stenting. But even this was significantly more than those in standalone balloon angioplasty. So the authors suggest that balloon angioplasty may be a viable technique in patients who are younger with recent onset of symptoms, with lesions being softer and non-osteal and less wall thickening. Elective stenting should be considered in patients with severe wall thickening, chronic calcific osteal diseases, and older patients with resistant lesions. Cutting balloons led to more complications as compared to non-compliant balloons, with the complications included dissections and aneurysms. Progressive positive remodeling was seen after deployment of endografts in aortic lesions, as you can see on the panel at the top on the right. This led to very low pressure gradients in the long run. Visceral aorta was treated best by using wall stent. By their design, it allowed easy access to side branches, which was an added advantage for these patients. In smaller arteries, drug-eluting stents and bare metal stents had equivalent performances. However, these were applied in different kinds of lesions, so they cannot be compared directly. So in conclusion, this study demonstrates that percutaneous intervention is a viable technique for treatment of Takayasu's patients, which is safe and leads to good, robust, long-term results. Thank you for listening.
Ajay.
Yeah,
We can open the topic for discussion. Is Ajay around?
Yes, sir. I am here.
I think it's a
So the
very nice
most
topic.
important part is that we have to do targeted interventions, and the targeted intervention should be done at the time when the lesions are cold. So preferably all inflammatory markers are very important. Preferably repeated interventions most of the time are required if the phase reactants are not under control and the disease activity is not under control. And for the management of aortoarteritis, though interventional cardiologist is important, but according to me, the most important person is the rheumatologist who can take care of anti-inflammatory scenario in that particular patient and disease activity in that patient. And only those symptomatic lesions we have to treat, and sometimes we have to do repeated interventions.
Ajay, but the medical management may not be uniform in all the patients. They will be different. Actually, the steroid dosage and mycophenolate may be variable according to rheumatologists, and it doesn't make any difference. Actually, the whole management. Aggressive medical management might make difference. In fact, the restenosis rate and other thing.
See,
doctor.
preferably the intervention should be only balloon dilatation. Only at the rescue situation, one should go with a stent implantation, provided the lesion is cold. In cold calcified lesion, one can go with directly stenting, but it should be after the age of 40.
Thank you, sir. Sir, Dr. Akshay Mehta, sir, your
Yeah,
comments.
yeah. The strategy of whether to use only the balloon or with adjunctive stent or covered stent, all will depend on the anatomy. But when to intervene will depend on the threat to the organ and the disease activity. So supposing there is no acute threat, then I think disease activity has to be gauged by biomarkers. Many times biomarkers may not be enough because they may not tell you the correct picture sometimes. And sometimes biomarkers are low, but the disease is active. So many times one has to do a PET study, FDG PET, of the arterial wall, and that can tell us whether the disease is active or not. In case where there is a threat to life or severe hypertension or organ damage, then even if the disease is active, one can give strong pulse doses of steroids and immunosuppressants. And that is what the people, the article says, that is what they did. That in case of urgent situations, you do both the things simultaneously, give immunosuppressants, steroids, and do the intervention. But where you can wait, you can study the activity, disease activity, and then do. So I think there are two things. One is the disease activity, telling you the time and urgency. And the other thing is the anatomy of the whole disease process, whether there's calcium, whether the walls are thickened, whether it's osteal disease. And depending on that, we use only balloon. If we use only balloon and get a little bit, then I think the results are very much better. So this whole study has given a great hope to all of us in treating such patients.
6% of patients received anti-TB treatment. What was the criteria for giving anti-TB? And in India, the scenario is different. I think we give more people anti-TB treatment. There's a study that mentioned 6% of the TB data. What was the criteria for giving anti-TB? And is it something different? Because
I don't think
Ramesh,
so.
this 6% TB was received earlier. They were not given that
not
time.
before diagnosis, actually.
Yeah. It might have been given by somebody else who has done as a TB. That's one. And this is an Indian study. So that means the TB incidence in autoarthritis is much negligible. That's what I believe now with this study. So it's basically an autoimmune problem and nothing to do with the
Dr.
TB.
Kane, sir, your specific comments on the study.
Yeah, I have specific. No, this study is fabulous. There is no doubt about that. I think this is one of the largest experience in the world that Dr. George Joseph has accumulated over a period of number of years. So hats off to him for doing such a. The only problem what I face with this study is you need to read this article several times. It has almost included everything possible into that small presentation of theirs, because I'm sure energy to collect all the data and write it. But what I have to say is that this balloon dilatation, what I've realized, and whenever I have done few cases earlier of late, I have not done an aorta arthritis. Sometimes you have to use very high pressures. You have to use pressures of almost 30, 40 atmospheres. And you have special balloons for that, called as Conquest balloon from Bard, which goes to high pressure because these lesions are very, very tough. And you have to have a covered stent all the time with you, because you may not be sure what will happen when you go to high pressure, but otherwise you don't get a result. And even if you want to put a stent, you have to use high pressure first to dilate the lesion. That's one thing. His use of Boston Scientific's, which is that stent which for aorta, I mean, below the renals, you can use that stent because you have better chances of and above this branch, you can access branches through this stent. That's one of the advantage. But otherwise, aortic lesions, because they are large aorta and all, you put a endograft, they give the best result. And I have had some experience with this PET scan, because even if your ESR and this comes down, PET scan many times shows you that the activity is still persisting. And PET scan is a gold standard today to identify persistent inflammation in the aorta and its branches. So most of our neurologists, rheumatologists in Hinduja, whom I have associated with, they always repeat the PET scans at serial intervals to see what is happening. I have no experience with repeated, but I know that aorto-ostial lesions, covered stents are the best. And this hyperperfusion and all, I have no experience because I've never touched a bald arch and all like the way he has done it. So
That's it. This is a very diverse kind of experience, and thank you, sir. And Dr.
Can I make some comment?
Dr. Juwale, sir, we are a little short of time.
Yeah. I just wanted to make
Dr.
2 points.
Juwale, sir, I wanted to call.
Yeah, one is in acute coronary syndrome, you may encounter a patient with acute myocardial infarction, and patient may have osseous disease. Of course, the imaging will change the situation now. But if it is emergency and if there are signs of inflammation with acute disease, please do not stent that particular lesion. Just dilate it and give immunosuppression, and the lesion subsequently subsides. It doesn't require stenting in left. There may be 4 different types of acute coronary presentation. That is, they may have osseous disease, they may have long lesions, they may have spontaneous dissection, and they may have aneurysm. And second point is about surgery. Whenever you are using internal memory grafts, be careful that subclavian artery may be diseased. That disease may progress and may occlude your lemma. Not only the subclavian artery, but even the origin of lemma is involved in aortoarthritis. So sometimes they recommend venous graft. Now, as far as the venous grafts are concerned, even the connection of the venous graft to the aorta is through a graft, not directly implanted into the aorta, because that disease can progress, go into the vein and cause subsequent blockage.
Very, very important point.
Milind, couple of comments.
Dr. Bhagwat, sir, just needs to make a quick comment before.
Yeah, the good part of the study is there is hope for intervention. Even if suppose there's a restenosis or recurrence, the repeat intervention has been shown to be very rewarding, promising. So I think it's a game of patience. Number 2, I think there is scope for trying all these new drugs that have come up, all these MABs, axipizumab, all those drugs for immunosuppression and all. And there was some study on use of azathioprine and all these drugs. So that is not mentioned here. Whether they have been found to be ineffective or not, we don't know. But if immunosuppression goes on, they also possibly may have a role to play on a long-term basis. Yeah.
Dr. Ajay Mahajan rightly pointed out that the rheumatologist is very much a part of the team.
Milind, can I make some comments?
Yes,
they have used only mycophenolate and steroids, nothing else, I think so, if I'm not mistaken.
Milind, can I make some comments?
Yeah, please, sir, please.
Yeah, a wonderful article. Of course, as everybody has said, it is given scope for us to intervene in these patients. But there are certain things which I'm a little worried about or concerned about. We know the larger the artery you intervene, the lesser are the chances of restenosis in these cases. So the aortic part, which they have tackled, naturally we know that the restenosis is going to be lesser. But when we talk about renal arteries or coronary arteries, which are highly fibrotic in these cases, the chances of restenosis is going to be much more. That is what I feel. The second thing which was a little confusing is that these are highly fibrotic lesions. We have tackled a lot of them, and particularly in renal, we have used cutting balloon. And here the incidence of using cutting balloon giving rise to perforation was quite high. That was a little surprising for me as far as interventions were concerned. And the last thing, as far as coronaries are concerned in Takahashi disease, they are mostly ostial lesions, do not involve the stems or the thing. So in these cases, we find that balloon dilatation does not suffice for these patients. You have to use a cutting balloon for these cases. Of course, as they said that the chances of perforations and dissections are much higher, but then you have to be ready with the covered stents for these things. That's it.
Thank you, sir. And probably as we use imaging more and more, that will add more insights into this kind of thing. Thank you very much, sir. I request the technical team to now please start the second presentation. We have had a very informative discussion. Please.
A very good evening to one and all. Today I am going to be presenting the trial Valor HCL, which is myosin inhibition in patients with obstructive hypertrophic cardiomyopathy referred for septal reduction therapy, which was published in the JACC in the year 2022. As we all know, hypertrophic cardiomyopathy is a disorder characterized by cardiac muscular hypertrophy, which may even lead to left ventricular outflow tract obstruction. It is an autosomal dominant disorder running in families caused due to mutations in the contractile elements of the heart. It is prevalent in such a way that around 1 in 200 to 1 in 500 patients may have, and around 66% of the entire population of the hypertrophic cardiomyopathy have obstruction. Patients with obstructive hypertrophic cardiomyopathy have left ventricular outflow tract obstructive symptoms, that is LVOTO symptoms, like angina, dyspnea, syncope, heart failure, and even poor exercise tolerance. As we all know, it is a common cause of sudden cardiac death. These symptoms are usually very progressive. The indication to treat patients with obstructive cardiomyopathy is typically with a gradient of more than resting gradient of more than 50 millimeters of mercury and outflow tract obstructive symptoms. The various treatment options that are available for these patients are either pharmacological therapy or septal reduction strategies. The septal reduction strategies are of two types. One is the open surgical one, which is septal myectomy, and the other one is an interventional strategy of alcohol septal ablation. Pharmacological strategies, as we all know, consist of beta blockers, non-dihydropyridine calcium channel blockers, and disopyramide. Now, one of the main issues with septal reduction therapy is that it is highly invasive and it requires the operative center to have a mortality rate of less than 1%, which is a very strict criteria, and it is very stringent, which is not that easily feasible for general practice. And also there is a very high risk of mortality and post-operative complications. Hence, there is a need of effective non-invasive therapy. Non-invasive therapy. The search was ongoing, but the drug mavacamten, which is an myosin inhibitor and reversibly inhibits the actin-myosin interaction and formation of cross bridges in the cardiac cycle. It came as a boon through the Explorer HCM trial, wherein it showed that it has significant symptomatic improvement in patients of hypertrophic cardiomyopathy. The other fact is that it reduces excessive LV contraction. So the primary objective of the study was to determine if addition of mavacamten in patients with severe symptomatic obstructive hypertrophic cardiomyopathy on maximally tolerated medical therapy significantly improved the symptoms, or to such a rate that they no longer meet the criteria for septal reduction therapy, or choose not to undergo septal reduction therapy at the end of 16 weeks of therapy. This criteria of 16 weeks of therapy was taken because based on trials it was found that the septal reduction therapy could maximally be postponed for 16 weeks without any further ado complications. The salient features of this trial is that out of the total of 112 patients who were randomized equally into the mavacamten arm or the placebo arm, both of them underwent sequential echo monitoring, and rather than pharmacokinetic monitoring at 4 weeks, 8 weeks and 12 weeks for the LVEF and also for LVOT gradients at rest and on Valsalva maneuver. And at the end of 16 weeks and at the baseline, they were evaluated for echo, stress echo and septal reduction therapy evaluation. The dose of mavacamten which was used was typically started at 5 milligrams and gradually up titrated up to 15 milligrams once a day as and when required during the study. Patients who required to be included in the study needed to meet certain criteria of being more than 18 years of age. They required to have severe symptomatic hypertrophic cardiomyopathy with a gradient of resting more than 50 millimeters of mercury, or with Valsalva maneuver or exercise it had to be more than 50 millimeters of mercury, a documented LV ejection fraction of more than equal to 60%. Patients needed to be with NYHA functional class 3 or 4, or in case they had syncope or exertional syncope, they needed to be class 2 symptoms. And Also, the other thing was, which is a salient feature in this trial, is that disopyramide was also allowed to be taken alongside mavacamten, which was not a criteria in the Explorer HCM trial. And the criteria for diagnosing HCM was purely on the core lab echo laboratory criteria, where the thickness of at least 15 mm was needed, or in patients who had a family history of hypertrophic cardiomyopathy, a thickness of at least 13 mm was needed. And these patients were evaluated at baseline for septal reduction therapy, and so as a result of which they needed to have criteria, they needed to be satisfying criteria to undergo septal reduction therapy at baseline, and for that they needed to have been evaluated within the past 1 year. So all of these patients were evaluated for two main endpoints. One is the primary endpoints, the others are secondary endpoints. The primary endpoint was a composite of the patient's decision to proceed with septal reduction therapy, or those patients who at the end of 16 weeks continued to meet the criteria to undergo septal reduction therapy in the patients of hypertrophic cardiomyopathy. The secondary endpoints which were tested in this trial were comparison of the baseline criteria to the 16 week criteria of post exercise LVOT gradient, patients who have any change or improvement in the NYHA class by at least one class, change in the Kansas City Cardiomyopathy Questionnaire clinical score, or change in the NT-proBNP or troponin I levels. At baseline evaluation, it was found that both the populations were adequately matched with respect to the age, gender, family history of hypertrophic cardiomyopathy, NYHA class, the type of septal reduction therapy which was recommended to these patients as either alcohol septal ablation or myectomy, medical therapy which was ongoing for these patients, the resting LVOT gradient, as well as the post exercise LVOT gradient. Overall, one salient feature was noted was that patients, around 20% of the entire patient population, was on disopyramide, either in the form of monotherapy or combination therapy. The other factors were overall adequately matched, that there was not significant difference among the population which was in either group. The primary endpoint, in particular to the intention to treat population, there was a significant improvement in the patients who were on mavacamten with respect to the fact that the number of patients who chose to undergo septal reduction therapy voluntarily was very low in the mavacamten arm as compared to those who were on the placebo arm. At the same time, patients who were on mavacamten at the end of 16 weeks of therapy, there was significant reduction in the number of patients who were meeting criteria to undergo septal reduction therapy at the end of 16 weeks as compared to the placebo arm. So similar to the criteria to undergo septal reduction therapy, or the patients need to undergo septal reduction therapy, the NYHA class improvement also was significantly higher in patients who were taking mavacamten. It was noted that around 63% of the patients had at least one class improvement in the NYHA classification, and at least 27% showed improvement in the two class NYHA class symptomatic status, whereas that was not at all observed in the patients who were on placebo. Hence, it had significant improvement in the NYHA class of symptoms in the patients. Another important difference in the secondary efficacy endpoints which was noted was the change in the LVOT gradient at rest and after Valsalva maneuver. The difference which was noted between patients who were in the mavacamten arm whereas those who were in the placebo arm, there was a significant difference in the gradient, that the resting gradient significantly fell at the end of 16 weeks in the patients who were taking mavacamten, whereas it did not reduce even by 10 to 15 mm of mercury in patients who were on placebo. The similar findings were noted at the end of 16 weeks even with Valsalva maneuver. With respect to change in the LV ejection fraction or the Kansas City cardiomyopathy clinical summary score at the end of 16 weeks, it was noted that there was not much significant change in the LV ejection fraction for both the placebo as well as the mavacamten arm, whereas with respect to the Kansas City cardiomyopathy questionnaire score, there was a significant improvement in the symptomatic status such that the score improved significantly in patients who were in the mavacamten arm as compared to those who were in the placebo arm at the end of 16 weeks. Similarly, significant improvements in the NT-proBNP and troponin I levels occurred in patients who were in the mavacamten arm as compared to the patients who were in the placebo arm. The mavacamten arm significantly reduced the NT-proBNP and the troponin I levels in patients at the end of 16 weeks, similar in lines with the patients who had improvement in the symptomatic status. On comparison of the adverse events in the safety population between the mavacamten arm and the placebo arm, it was noted that the mavacamten arm had slight reduction in the ejection fraction to less than 50%, which was noted in around 3.6% of the entire population, which was not seen with the placebo arm. However, none of the patients had significant reduction in the ejection fraction to less than 30%, or none of the patients developed any serious adverse events, sudden cardiac death, cardiac failure, or syncope. There were some interspersed events of non-sustained ventricular tachycardia among the patients who received placebo, and similar findings of chest pain, fatigue among these patients. There was nausea, headache also noted occasionally. In spite of such good results of this trial, there are certain limitations with respect to the fact that the primary endpoint is completely a guideline-directed goal with an eligibility assessment of the patients for septal reduction therapy. The other factor is that there is no definite proof of long-term safety of this drug or long-term benefits of these patients of taking mavacamten. There is no definite proof of any improvement in the prevention of lifelong arrhythmias or even sudden cardiac death. Also, the long-term benefits, whether it will be sustained over a long period of time by taking this drug, is not definitely proved. The other factor is that the predominantly white patients were taken at centers which were high volume HCM centers and who had established septal reduction therapy programs with a complication rate of less than 1%, which is not a very feasible alternative. In conclusion, Valor HCM gives us certain important learning points that in patients of obstructive hypertrophic cardiomyopathy with intractable intolerable symptoms, the administration of the drug mavacamten can significantly reduce the eligibility of these patients to undergo the complicated procedure of septal reduction therapy, and it can be titrated using a non-invasive investigation like echocardiography. Other factors are that there is significant improvement in the Kansas City cardiomyopathy questionnaire clinical scores, improvement in the NYHA clinical status. There is significant reduction in NT-proBNP and troponin I levels in these patients, as well as significant reduction in the resting as well as post-exercise LVOT gradients at the end of 16 weeks of taking the drug mavacamten. However, the long-term benefits of this drug still need to be evaluated, and whether there is going to be any benefit in preventing life-threatening arrhythmias and sudden cardiac death still needs further evaluation. Also, the other factor is that the safety of using this drug with disopyramide, beta blockers as well as calcium channel blockers has been demonstrated in this study. Thank you.
Thank you very much, Dr. Sriram. And I will now call upon our first expert, Dr. Zoeb Sheikh, Associate Professor in NTMG. He has studied this article quite thoroughly. So could you please give some of your comments, Zoeb?
See, this study is a phase 3 trial, which is compared which is mainly you compared utility of a drug called mevacamtan, which is a cardiac myosin inhibitors. It decreases actin and myosin cross bridges, and thereby it achieves pure inotropic effect without much effect on chronotropic. It has been studied earlier in earlier trials, being Pioneer or Explorer trial. In Pioneer trial, it used in non-obstructive HCM, where it was found to bind to significant decrease in LV ejection fraction. There, it showed decrease in peak size gradient, increase in improvement symptom class. But the effect, but overall, there were red flags raised as far as the LV decline in EF is concerned. Similarly, there's a previous trial to it, known as Explorer HCM trial, wherein it is a phase 3 trial in patients with hypertrophic cardiomyopathy, where numbers were much more. 251 patients were studied. These were essentially patients with class 2 NYHA symptoms. Here also, there was significant improvement in symptoms, improvement in peak VO2 max, decrease in LVO2 gradient, but mind you, here also 11% drop in LVEF, though this was transient. Now coming to Valor HCM trial. Now Valor HCM trial is another trial where we have studied patients with hypertrophic obstructive cardiomyopathy. But this different in this trial was mainly because of we have taken patients in NYHA class 3 and beyond. Majority of patients, around 89% were in NYHA class 3, and those who are awaiting septal reduction therapy. They were divided equal groups. What was alarming here, that significant number of patients reduced were in the control arm did not choose to undergo septal reduction. There was significant reduction in gradients both in resting as well as Valsalva group. Now, though this seems to be promising, there are around two patients in this, around 51 of 2 patients developed decrease in LVF, where drug has stopped and it has reversed. What is important here is whether this effect is long term, whether this effect of these drugs stays for long, whether it causes reverse, whether it causes long term use significant or reversible or irreversible decline in LVF needs to be seen. One more interesting element needs to be seen, whether if this drug proves its worth in the long term, will it have some effect on the arrhythmia suspect or AICD? Will it have some effect on the arrhythmia suspect or not? Here we saw patients more than 60 years of age, where more or less arrhythmias don't play a much role. So this needs to be seen. Though this is an interesting avenue, there are lots of doubts which needs to be answered. A long-term study will be able to answer these doubts.
Yes. So thanks, Dr. Zoeb. Very insightful comments you have mentioned about the methodology and even the concerns about the decrease in ejection fraction, the benefits on arrhythmias, the long-term aspects. Now I please call upon our second expert, Dr. Yash sir, to in his own inimitable style to please analyze this article and give us a perspective.
Am I audible, Milind?
Yes, yes.
Can my screen be seen?
Yes,
Yes,
absolutely.
So yeah, it is definitely an interesting avenue, and something more needs to be done for HCM, which is not such a rare disease. Now I am going to go to this article and I'll come back to this. I have highlighted certain things. I'll come back to the authors of this article later. But let's go to some of the things that struck me is that they said a post-operative mortality was around 6 to 15%. Now, as said before, this sounds to be pretty high, and the type of patients we see with hypertrophic cardiomyopathy who go for myectomy. The problem with myectomy has been less surgeons who were doing it in the past, but now many surgeons do a fair job of myectomy, at least in Mumbai. And I have yet to see a mortality with myectomy, but I have seen with alcohol, which of course is only in high-risk surgical patients. Interestingly, also, if you look at this study, they said the medical therapy could even include disopyramide. So this is intention to treat. So we all think by reading this paper that yes, these people had already failed disopyramide. Now look at the actual table of how many took disopyramide. Zero. Zero patients were on disopyramide only. And disopyramide plus beta blockers in the mavacamten group, so 11 and here 3. Authors did a lot of good statistics and a lot of reputed authors, but they did not bother to show us any p-values in this table. So when you, this for the students especially, even if it's a reputed journal, even if there are big names, start with the null hypothesis that until something is proven true, it can be either way. People keep saying that whether this will reduce arrhythmias. No, it has to be a two-tailed test. Can it also increase arrhythmias? When you're removing the bridging of actin and myosin, either way could happen. Apart from EF, and we know that EF going low actually makes you higher risk for sudden death. So don't always think, will this reduce sudden death? It could reduce, it may be neutral, it could even increase. So keep an open mind. And simple chi-square test here shows you that many more patients in the mavacamten group were on beta blockers, but still it amounts to only dice. And we know from Kanu Chatterjee's textbook that hypertrophic obstructive cardiomyopathy, the best drug, and we are talking here of NYHA class 3-4 patients. So those who generally would fail, no gradient, calcium blockers, exercise gradient, beta blockers, resting gradient, disopyramide. So very few patients in this study were actually on disopyramide, yet the intention to treat makes you think that these patients have already failed disopyramide. It's why I'm saying this is important. I'll go back to the authors. When we sign so many papers, we never read the fine print. Why I pointed out about these authors is any study's scientific validity depends on its impartiality. This was totally funded. This study is totally funded by a pharma. Now, if you read any values of any studies, ones which are funded fall lower in the value. The first 2 authors are consultants of this company. So is one more author, and 4 of the authors are employees of the company. So out of 16 authors, 7 have direct sort of obligations to the company. Keep this in mind. I'm not saying they are wrong. I'm not saying this is not true, but many times things are not as they seem. Skimmed milk appears as cream. Remember that. Now, if you look also at the editorial, there's an editorial in this. And in the editorial, it says that the vast majority, this is not I am saying the editorial, of hypertrophic cardiomyopathy patients can be successfully managed with the existing drugs. And as Zoeb said, and as even Sriram said, be careful in the long term. This is a 16-week follow-up. We do not know this fall in ejection fraction, what it will be do in the long term. So these are my comments. This is a preliminary study. And the last comment would be, if I can share my screen and show you this, that institutional academy industrial relations from JAMA have gone to such an extent that they could endanger the trust of the public.
Yes, sir. Could you share your screen?
We can't see your screen. We can't see your screen.
Okay, I can't see my screen. I'm sorry. It says that where is the share screen? Yeah, I'm sharing the screen now. Yeah, here it is. Can you see this now?
Yes, sir. Yeah. Yes.
Yeah. The things have reached to such a level that this is JAMA saying this in 2007, that institutional, academic, and industry relationships have reached such a level that they could endanger the trust of the public in medical schools and teaching hospitals. And the last comment, cost of mavacamten was projected to be $75,000 a year. The Institute of Clinical and Economic Review says a fair cost will be 10 to 12 lakh rupees a year. So I end my comments.
Cheaper. Yeah.
Yes, sir. Thank you. As usual, your analysis is very fascinating. This time a little contrarian, but I really am grateful to you for these comments. And now I call upon our first panelist, Dr. Anand Rao, sir, you to please.
Yeah, thanks, Milind. I understand. I went through this article. There are a lot of pitfalls in this article. There's no question about it. As Yash sir has pointed out, about conflict of interest to 0% isopyramide, and plus the cost, plus the short study of this. I agree with all those things. But let's keep our mind open. And as all the drugs and the devices are coming down in cost, I'm sure a long-term study will come where it will show some benefit, whatever it is. At least we are having a drug right now in the site, so maybe we have some hope to avoid these patients for myectomy and septal alcohol ablation. I agree with Dr. Yash sir completely. Recently, one patient got operated of mine. The myectomy mortality rates are really come down. Patients, they're good surgeons out here and they operate and they go home in 6 days or 5 days. We have at least 10 or 12 patients right now in our Holy Family Center, and we have been seeing that. So, small experience, but whatever it is, myectomy patients have done well. So my submission is, yes, cost, duration of the study, all those things are an issue, but at least we have something to look forward. Those are my comments.
Thank you, Anand sir, especially for emphasizing the fact that surgical myectomy still remains the thing to beat in the treatment of hypertrophy.
No question about it.
Absolutely. Now, Dr. Nihar, are you there? Please, could you just give some comments?
Yeah, thank you so much. So I think there have been some fabulous comments which have already been made by Dr. Zoeb, Dr. Yash sir, and Anand Rao sir. I have just a couple of things to add. That we must always see it takes a long time for a new drug to come into the forefront nowadays. After disopyramide, I don't know how many years back, 20 or 30 years, there has been nothing new which has come up. So while we take any new drug with a pinch of salt, we should also see the benefit. By the study and by the numbers that they have given, there was a reduction in the gradient by as much as 33 millimeters of mercury, reduction in BNP, reduction in improvement in the quality of life. Even the LV mass has been shown to be reduced a little bit compared to placebo. And that does, I think, it might or might not impact the future long-term outcomes. We don't know yet. But having said that, the main pitfall of this drug, according to me, is the reduction in the ejection fraction. Because it might be very simple to say that the ejection fraction went down to less than 50%. But by every criteria of hypertrophic cardiomyopathy and the guidelines that we follow, ejection fraction less than 50% is even one of the risk factors for sudden cardiac death. So are we, we have to sort of understand what are the risks when we add this drug and whether it is going to add to the risk of sudden cardiac death, not just being neutral to it. So with these comments, I would like to say that while this drug is promising, exciting, it should also be taken with a pinch of salt before we start using it commercially. And of course, the cost in India will be a major factor.
Thank you, Nia. Very important. This is a genetic condition. This is going to be a lifelong treatment. So we really have to be sure about the cost-benefit ratios before committing the patient to expensive therapies of this kind, and of course, with all the possible side effects. And Dr. Vaibhav, please, you're the third panelist. Could you please share some of your thoughts on this article?
Yeah, so good evening, everybody, and very interesting article and very interesting study. But besides the very short duration of follow-up, one thing concerns me is the way this drug works, and which really none of us have given, not included in our discussion, is it works by inhibiting the actin-myosin link in the cardiac muscle. When I was reading this article, one thought came to my mind is how can this drug be only cardioselective? Will it affect the skeletal muscles as well? Because even the skeletal muscles have actin-myosin links. And nowhere in the study have they mentioned about skeletal muscle weakness or any observations regarding this this particular side effect developing. So I would be really concerned about using this drug for patients, not because of the cost, but because the outcome data does not anywhere mention about the possible adverse effects it could have on skeletal muscles. So I think we should be very careful before we go gung ho about this drug and start using it, even if the cost would come down. I think it requires more stringent study on the possible adverse outcomes, because of the way it acts.
Yeah.
Thanks, Vaibhav. And one
Yeah.
explanation for that could be that this is specifically an inhibitor of cardiac myosin, which is slightly different in structure from the skeletal muscle myosin. So that may be the reason why skeletal muscle side effects have not been seen to any appreciable degree, because they always call it a cardiac myosin inhibitor.
Yeah.
Milind, does it actually act in myosin? Should it help with the patient with a preserved ejection fraction failure also, apart from hypertrophy? Because actin myosin will be the mechanism which should help it.
No, actually, with preserved ejection fraction, hypercontractility is not the chief mechanism. It is the rise in the filling pressures plus the multiple systemic factors. So I think reducing only the contractility should not be the issue in FPEF. It's multisystemic basically. We need to tackle that. Ajit sir, your comments please.
Yeah, Milind, a nice article, but I would fall on with Yash that there are so many things which have not been put forward as far as this particular article is concerned. For me, the most important concerning factor as far as the drug itself is concerned is the arrhythmia and the sudden cardiac death which is likely to occur in this patient. And more so if the ejection fraction is falling on this particular sudden cardiac death or arrhythmias are going to increase significantly. Also, I would have been happier if the drug was compared to the standard drugs which are used for hypertrophic obstructive cardiomyopathy. Say maybe disopyramide or this thing. We are talking about a drug which is compared as far as a placebo is concerned. If that is the case, then I don't think it throws forward what is the effectivity of this particular drug vis-a-vis its side effects. So I would have been much happier if a head-on comparison of this drug was done with maybe disopyramide or beta blockers against mavacamten and not with the placebo. That's it.
Thank you, sir. I mean, I'm so happy we have had this journal class. Just one article can elicit so much discussion and so many insightful comments from senior people. And thank you very much, sir. And I request all the panelists to stay online because we have another good article coming up, the third one. And I request the technical team to please play the article.
Very good evening, respected teachers and my dear colleague. Today I am going to discuss about a review article of valvular heart disease, shifting the focus to the myocardium, which was recently published in European Heart Journal. So basically, valvular heart disease affecting more than 2% of general population. Whenever valvular heart disease is significant, initially some adaptive changes like chamber hypertrophy and dilatation occur. Later on, maladaptive changes occur like microvascular ischemia, cell death, and fibrosis, which leads to decline in ejection fraction. Number of myocardial changes occur before ejection fraction goes down. These are the changes which listed over here, and some of these changes are easily detectable by neuroimaging parameters. So this article tells us how with the help of advanced imaging by echo and cardiac MRI detect early myocardial changes, and according to which we can plan for surgery. So in the severe MR, initially some adaptive changes like LA-LV dilatation occur, but pulmonary pressure remains normal and EF remains falsely normal or supranormal, and patients are asymptomatic. Followed by some maladaptive changes like myocardial remodeling and fibrosis develop, which leads to LV dysfunction. Later on, pulmonary hypertension, secondary TR and RV dysfunction develop. So we all are aware of the standard echo parameter by which we can decide when to send patient for surgery and how to monitor, which are listed over here. Some of the same parameters can also be detected on MRI. Additional one is LV mass and RV volume. On the other hand, number of new imaging markers are come up in last several years, which can detect LV dysfunction and myocardial remodeling much earlier. These are listed over here, and I will describe some of them subsequently in details. These are the echo finding in a strain of primary MR patient. First image shows severe MR in 4-chamber view. Second image shows apical part has better LV contractility in a strain, but less in mid and basal part, and lowest at the inferior and posterior part of LV. So basically, GL is a good prognostic marker and can detect subclinical LV systolic dysfunction. Several studies show if GLS more than 21% had better outcome after mitral valve surgery as compared to less than 21% in case of primary MR. This image shows the LA reservoir strain, which is impaired significantly. Basically, LA reservoir strain reflecting LA compliance and help in early detection of LA remodeling. In recent study, LA reservoir strain was independently associated with all-cause mortality with cutoff value of 22% in patients undergoing mitral valve repair for primary MR. This image shows mechanical dispersion. Basically, mechanical dispersion of longitudinal strain defined as the standard deviation of time to peak longitudinal strain, or it's a time from ECG onset Q to peak longitudinal strain. It's a newer and more sensitive echo marker to detect early and subclinical AV dysfunction. So, patient with the MVP, those with symptomatic ventricular arrhythmia, had worse GLS and more pronounced mechanical dispersion as compared to without ventricular arrhythmia despite having similar EF. So it's a marker of LV dysfunction and long-term prognosis. So late gadolinium enhancement and ACV are advanced cardiac MR imaging biomarker which help in early detection of myocardial changes. First image shows the extracellular volume fraction. Extracellular volume is the composition of interstitium and extracellular matrix. ACV increase because of excessive collagen deposition. It help in early detection of myocardial remodeling. In this image, blue areas are normal, red areas are abnormal, and orange indicate blood. Image A and B are normal. Image C shows some microscar in inferolateral part. Image D shows excessive collagen deposition, which indicate poor outcome. Right-sided image is a short axis view with normal LV and RV with no gadolinium enhancement. So basically, LG occur because of non-viable myocardium unable to wash out gadolinium. It helps in detection of pattern of fibrosis and scar. LG is also known as irreversible fibrosis or replacement fibrosis. Arrow indicate LG in short axis view. In MR patient, replacement fibrosis is more common in MVP patient than non-MVP patient. Fibrosis commonly located in segment which adjacent to the posterior medial papillary muscles, and the fibrosis act as a arrhythmogenic focus. CV fraction is also known as reversible fibrosis or diffuse interstitial fibrosis, similar in both MVP and non-MVP group, and associated with the severity of MR, means a higher in symptomatic MR patient and correlate with oxygen consumption and LV function. If ECV more than 30% indicate higher chance of ventricular arrhythmia and death and need urgent mitral valve surgery. In MVP patient with replacement fibrosis, 2 to 3-fold increased risk of heart failure, arrhythmia and death. Some studies show significant reduction in ECV fraction after valvular surgery, but not in LG because LG is irreversible fibrosis. So regular follow-up with this new imaging biomarker help in early detection of myocardial changes and timely intervention. Myocardial response in aortic regurgitation. Because of chronic severe AR, volume overload and myocardial fibrosis develop, which leads to LV dysfunction and patient need early intervention. In AR patient, if LV and systolic volume more than 45 ml per meter square, then post-op mortality is high. These are the newer biomarkers. Some were described earlier and are helping early detection of myocardial remodeling. Other newer biomarkers like myocardial work indices, which quantify global LV function, and it's a product of SBP and strain. LV is impaired early in the course of disease and a marker of AR severity, while circumferential and radial strain worsen later. According to Alci et al. Study, patients who had GLS less than 19.5% high posterior mortality as compared to more than 19.5% GLS. By using newer imaging biomarker, cardiac MRI also helpful in early detection of LV remodeling, quantification of AR and fibrosis. And fibrosis increase 2 to 3-fold in mortality. It's mitigated by AVR. So regular follow-up with these biomarkers are necessary for timely intervention. These are the cardiac MRI images. A and B shows the discrete subendocardial infarction at mid-anterior septum part. C and D shows increased wall thickness with normal ECV and no replacement fibrosis. E and F shows mid-wall fibrosis at basal anterior septum part and elevated ECV fraction, which indicate left ventricular remodeling. Myocardial response in aortic stenosis patient. In AS patient, progressive LV hypertrophy occur, which leads to supply-demand mismatch, ischemia, and fibrosis. Ultimately leads to LV dysfunction. If wall left untreated, leads to myocardial loss and three distinct patterns of fibrosis develop. First one is thickened endocardium. Second is irreversible microscarring in subendocardium. Third is interfiber and perivascular fibrosis throughout the myocardium. These are the imaging biomarkers which were described earlier and are help in early detection of remodeling. Several studies show that GLS was impaired in patients with severe AS even with preserved EF and absence of symptom and need aortic wall replacement surgery early. As compared to severe AS, in patients with severe AS with ATTR amyloidosis, LV is more thicker, more impaired GLS and lower stroke volume and worse LV diastolic dysfunction observed. In some patients, improvement in GLS is also seen after AVR surgery. This image shows despite a preserved LVAF, GLS is significantly impaired in anterior anteroseptal and inferoseptal mid and basal part. Cardiac MRI is more sensitive than echo to identify altered LV geometry. In AS, male has high maladaptive myocardial response because of high index LV mass, lower EF and high myocardial stiffness. In AS patient with help of ECV and LG, we can easily detect diffuse fibrosis and patchy non-infect pattern of scar. Higher LG associated with higher chance of mortality regardless of type of LG. EVOLVE trial is an undergoing trial and assess early intervention in asymptomatic AS patient on the basis of LG. In many patients post AVR, ECV regression occur but not in LG because of LG's irreversible fibrosis. These are the echo and cardiac MRI images in severe AS patient. In image E and F, arrow indicate late gadolinium enhancement. Myocardial response and tricuspid regurgitation. Because of pressure and volume overload leads to RV ischemia and myocardial fibrosis. Histological changes and myocardial fibrosis more common in pressure overload condition as compared to volume overload situation leads to RA and RV myocardial remodeling. Functional parameters of RV affected by preload and afterload RV ischemia and interventricular dependence. So RV functional imaging is indirect marker of RV remodeling. We all are aware about the standard echo and cardiac MRI marker, which are listed over here. Some are new biomarker like RVPA coupling, RV strain are also helpful in early detection of RV remodeling and timely intervention. This image shows global RV longitudinal strain and free wall RV strain in 4-chamber view. Many of the company are not providing separate software for RV longitudinal strain. So often the LV longitudinal strain software is used to calculate RV longitudinal strain. According to Silverton et al. Study, if RV strain less than minus 20% indicate RV dysfunction and high post-op mortality. RVPA coupling is the index of ventricular contractility to afterload used for tricuspid valve intervention and assess prevalence of post-op mortality. It's a ratio between TAPSE and pulmonary artery systolic pressure. If ratio is less than 0.40, indicate post-op mortality is high. So cardiac MRI is gold standard for quantification of RV remodeling and RV function. It evaluates extent and pattern of myocardial fibrosis. These are the echo and cardiac MRI images in severe TR patient. Image A shows severe TR in 4-chamber view. Image B shows RV free wall longitudinal strain, which is minus 6.9%, indicate RV dysfunction and poor post-op outcome. Image D, E, F, G are cardiac MRI images. Arrow indicate late gadolinium enhancement at the junction of right and left ventricle. Image G shows T1 mapping image and shows microscopic fibrosis at the junction of right and left ventricle. Limitations are novel imaging biomarkers are still largely underused because of lack of availability and cost. Post-contrast T1 mapping value have greater variability, limiting their clinical applicability in multi-center studies. Clinical implementation and expertise for the interpretation and reporting needs to be coupled with data acquisition, imaging quality, variability of the measure, and attention to potential confounders or artifact. So basically, in valvular heart disease, wall regurgitation and stenosis are primary insult, but myocardial changes determine prognosis. Various new echocardiographic and cardiac MRI biomarker are available which can identify myocardial changes early. Hence, this biomarker should be used in routine practice to identify at-risk patient and to refine timing of intervention. Thank you very much.
The reason for choosing this article was that now we all are dealing with valvular heart diseases on a regular basis. And apart from using the traditional criteria of ejection fraction and volumes, now that the new imaging modalities are universally available, including strain imaging, and now that MRI is also a very important part of the imaging armamentarium, we need to put all this in perspective, and we need to evolve a kind of working guideline or working date for day-to-day practice, which tells us how and when do we intervene in regurgitant lesions and to some extent aortic stenosis based on these parameters. So on our expert panel today, we have Dr. Ponde sir, who is one of the foremost experts in cardiac imaging in our whole country. And I would request Dr. Ponde sir to please put this whole article in perspective and tell us how we should go about using these modalities. Thank you, sir.
Thanks, Melinda. Can you hear me?
Yes, sir. Yes.
Can you hear me well? I don't know.
Not very well, sir. A little louder.
Can you hear me now? Can you hear me now?
Yes, sir. Perfect.
Yeah. Okay. Now, I think this article, I mean, it's a wonderful article, but I believe that myocardium is the status of the myocardium is the fundamental substrate which decides the outcome after surgery or intervention in valvular heart disease. We all have known that very well, but unfortunately, we all have been focusing on ejection fraction and volumes alone to determine the status of the myocardium. But now we have better imaging modalities like CMRI. We have better criteria on echo like global longitudinal strain, right ventricular free wall strain, left atrial reservoir strain, which are relatively load independent parameters of measurement of those chamber functions. Plus, the inter-observer variability which is there in ejection fraction is no more there or very little there in measurement of these indices like global strain, RV free wall strain, and LA reservoir strain. If good images are obtained and the person knows what is he doing, then the inter-observer variability is far much lesser as compared to that in ejection fraction. That is the second point. And the third and the most important point is that here I think this article has now stressed on the myocardial work. Now myocardial work, I believe I request youngsters to spend maybe 5-7 minutes more in an echo of valvular heart disease or any other heart disease. For example, even hypertrophic cardiomyopathy, dilated cardiomyopathy, post-infarct left ventricular systolic dysfunction of mild to moderate variety like mid-range ejection fractions and so on, and see their work indices. The global wasted work and the global work efficiency. These are the two most important indices which will determine over a period of years to come to determine what will happen to a given patient after intervention. So I think this article is really an eye-opener that we should start looking beyond ejection fraction. That is very important. In my lab,
ऑक्सीजन का प्रवाह शुरू करने के लिए ऐसे अपनी ओर खींचे और नाक और मुंह ढककर सांस लेते रहे.
Sorry. In my lab, there is a new echo machine which we have purchased, the GE, which has got artificial intelligence and which makes it further easy to measure all these indices very quickly. So maybe 10-15 minutes additional per patient and we will be through. So this is very important, particularly in aortic regurgitation patient. In aortic regurgitation and primary MR, the wasted work is high, and any wasted work of more than 160 millimeter mercury percent is suggestive that this patient will not do well and should be operated as early as possible for replacement or repair or whatever it is. So whichever modality that you can offer. The other importance of myocardial work again his myocardial work is almost entirely load independent. So you are not dependent on preload or afterload for determining myocardial work. And it takes into account the systolic blood pressure. It takes into account the myocardial relaxation mechanics as well. So it is like looking into heart in a global manner, like systole, diastole, isovolemic contraction, and isovolemic relaxation. So it's it's an entire basket. So I think youngsters should start doing all these parameters in an echocardiogram. Unfortunately, I see that youngsters are not at all interested in echo lab. They are all interested in cath lab. So that's a basic fundamental problem. And because of this, I think I keep my DNP candidates rotating every now and then in echo lab to measure these parameters. So it is very important. Really very important article. But to summarize, I'll tell you. Not this article, of course. I'm talking about the real evidence. In aortic stenosis, asymptomatic severe aortic stenosis with preserved LV function, if you have any GLS of less than -18, he should head for intervention. Anything -15 or below is an urgency. It proclaims urgency. And anything less than -12 proclaims or predicts a poor outcome after aortic valve replacement surgery or TAVR. In primary MR, the values are a little different. In primary MR, I would say any GLS of less than -20, the patient should head for surgery, because here the left ventricle is emptying into a relatively empty chamber, like the left atrium at the beginning of systole, and 50% of your regurgitant volume is emptied into the LA in isovolemic contraction period. Having said that, you can imagine then the GLS will be spuriously high. Though it is relatively load independent, it will be still spuriously high. So -20, which is almost like a normal GLS, will be a cutoff for primary MR for heading for intervention. And anything less than -50 is an inoperable patient, according to me. I mean, he will not do well, no matter what you do. He will progress to left ventricular dysfunction, the pH will progress, and he will remain symptomatic. In patients with tricuspid, primary tricuspid regurg, we had a series of 7 cases in the last 1 year, and RV free wall strain of less than -17 and global strain of less than -19 are again predictive parameters of whether they will do well or not. But I guess the message of this article is, please start looking beyond ejection fraction. Please start calculating global longitudinal strain in every single patient. Please start looking at doing RV-centric echoes in patients with primary tricuspid valve disease or organic tricuspid valve disease, along with mitral valve disease, primary pulmonary arterial hypertension, and chronic thromboembolic pulmonary arterial hypertension. Because it is the RV which will determine the prognosis of these patients, not the PA pressure, So suppose the PA pressure is 40, but your RV GLS, free wall GLS is less than -12, you had it. I mean, 3-year mortality will approach close to 50% in these patients. So this is the beauty of these articles. Now going to CMRI, unfortunately, Nitin is not here today. I think he's in the US, and therefore we couldn't have him here today. But Nitin always has held beautiful classes of all of us on CMRI. And he always tells us that extracellular volume is the first thing to go wrong in patients with left ventricular dysfunction because of valvular heart disease, AR or MR or AS. If the extracellular volume is high, you need to head early for surgery. And if your replacement fibrosis crosses more than 12% of the left ventricular myocardium, it is a sign of adverse prognosis. Of course, interstitial fibrosis is reversible, potentially reversible, as long as your GLS is in good range. But if the GLS goes in a bad range, even replacement fibrosis will not be reversible. And the left ventricular will remain or probably become worse after replacement surgery, particularly with primary MR. So this is what it is, Milan.
I think, sir, we have a lot of students registered for this program, and they will be very, very appreciative and grateful of the last 5 or 10 minutes, especially of what you have said. And I think if it makes them focus a little more in the echo lab, and it makes all of us assess these parameters, I think the purpose of this journal class is achieved. And
Yes,
now
and I think, Milind, most of the youngsters are now wanting to enter the money making branch of structural heart disease, right? Structural heart disease, and if it's structural heart disease, they want to know they must be excellent in echo. Otherwise, forget structural heart. They will never be able to do. Even case selection of a structural heart patient depends on primarily excellent echocardiogram. I hope you agree with that.
Absolutely, sir.
I mean, an echo is the right hand of the cardiologist, so we have to be thorough in echo. So,
Yeah.
Dr. Shetty, sir, on the panel, please, sir, please your comments.
Congratulations, Dr. Thakur. Very good presentation. You can hear me, na?
Yeah.
When Dr. Ponde is there, I think he has covered 9 out of 10 points what I had to say. But few basic fundamentals, what Dr. Thakur presented, from the normal adaptation to maladaptation, and from the reversibility to irreversibility of LV function. Whatever Dr. Ponde mentioned, ultimately our goal in valvular disease, whether it's a AS, AR, MR, or even for that matter TR, is to judge is the LV function is the going in a wrong way before you take a decision for surgery. In fact, 2 days back, during ACC CV symposium also, Patrick O'Gara, covered all these valvular heart disease and how this, the parameters are important in an asymptomatic patient. Many times, we just because patient has no symptoms, we hold on for the surgical therapy. By the time you recognize it will be already late. Only one point, as Ponde mentioned, possibly today is an era of multi, this speciality even in cardiology. For example, for me, I'm not into all these, all the advanced echocardiogram, but at least I will definitely involve my colleague in decision making. So fundamentally, what we as a clinician should know, what are our limitations? Person who is doing regular echo like me, routine echo is not enough. In these sort of patients, we have to pick up the abnormality early. GLS is one of the important things. And as Dr. Ponde mentioned, CMR with the Nitin being, most of our patients, we are jointly as a team approach like that. But we must recognize in time, just because no symptom is not enough. So picking up, just a reactive fibrosis and then the replacement fibrosis makes a lot of difference. Like a replacement fibrosis is almost irreversible. You may do surgery, but then the result is not good. So picking up the abnormality, pathology early, finding out the remodeling, is it adaptive or maladaptive? Is it a reversible or irreversible stage? And then the surgical result will be good. And that's what, by echo, advanced echo, GLS, MRI, so on. But again, I would request all the clinicians, you need not be expert in echo, you need not be expert in CMRI, but such patient, you involve multi-speciality team, and which is available most of the, the place like Punde now, when you want advanced echo, or, so many of our experts in different hospitals. So also MRI is available. And this is what my comment, but it's a very good, I think, paper. And in fact, a few days back, I have covered up extensively in my forum about this, but myocardium is important. I agree with you.
Yeah. Okay,
Thank you.
So we are running short of time, but Dr. Dargat, sir, I think needs to make a comment.
Okay. I think thank you, Radik Punde had made already all the comments. I think valvular disease were never unload valvular. The myocardium was very important. I think evaluation of myocardium is important. I think the echo, which has evolved, is a newer techniques of making help patients, and some cases where require CMR will be again helpful. Only the black is a good cat. But echo lab is lacking, like Ponde has got it, is not everywhere. I think we have to take help of that people. In this, all asymptomatic, I think aortic stenosis should be evaluated by good echo lab or MRI if required, and think other intervention can help him without becoming too late. But I think the echo evolvement, as he said, a lot of PG students are not interested. I think that you have to create interest now. And that is what is the main change I think we'll have to bring out. And more people with interested in echo should come out with these people, these type of patient to evaluate. And of course, CMR also will become little more affordable, and I think more people can be evaluated in some points where the fibrosis and all that can be more easily made out by the use of CMR. So I think the myocardial evaluation will be important in valvular disease. And then the tricuspid wall is always neglected. I think we always consider more of aortic and mitral. There are a lot of things well done, but I think when they said 7 cases, they said tricuspid evaluation is also always difficult and always neglected. Thank you.
Yeah, Milind, we had, I'll just tell you 2 more minutes. We had one patient, interesting patient, which the youngsters will like to hear this. A patient of aortic stenosis, now in the era of tower, no, everybody talking tower. So this guy had one episode of syncope. He came to our echo department, and Kaushal had seen him actually, and he referred it to me. I said, Ponde jara evaluate karo. So the peak by mean gradient was 90 millimeters by 50 millimeters of mercury across the aortic valve. Aortic valve area was 0.6 centimeters square. And patient, apart from that one episode of syncope, was virtually asymptomatic. No breathlessness, no dyspnea, nothing, no angina. And he had normal coronary arteries. Later on, of course, coronary angiogram was done. He had normal coronary arteries. Ejection fraction was bang normal, 60%. GLS was also quite good, around -18. Not the best, but -18. So I said, Kaushal, I think with one episode of syncope, you take him over. But we did not do his MRI. Okay, we did not do his MRI because the protocol of tower does not demand an MRI. It dissolves a CT. Patient refused tower, and because he could not afford, I think, and underwent surgery. And post surgery, 3 months, he had 6 more episodes of syncope. And then an MRI was done and showed 8%, whether it's replacement or what, I don't know, 8% area of fibrosis in the mid-interventricular septum. Yeah. And then a Holter was done and showed a sustained monomorphic ventricular tachycardia as a part of as a cause of syncope. And now he's waiting for an ICD. Can you believe that? So multimodality imaging, as Dr. Sadanan said, is the way to go. Whenever you have doubt, I think combine echo and MRI together.
The other point, Ponde, I don't think we should blame the PGs and all, because every specialty has grown so much, to learn everything about echo, you're going to forget other things. I would say, each one should take, sub-speciality, and we should be like a team approach. That's what my take.
Milind, I wanted to ask one question to Ponde. Yeah. Low flow aortic stenosis gradient. What do you think about this longitudinal strain and cardiac MR versus stress echocardiography?
Yeah. I'll tell you, low flow, low gradient aortic stenosis with reduced LV function. Still today, dopamine stress echo is the important, and it is the area and the gradients at a transvalvular flow rate of 250 ml per second, or projected aortic valve area and gradient at the level of the transvalvular flow rate of 250 ml per second will determine whether he should be he will benefit with surgery or not. But the problem is paradoxical low flow, low gradient aortic stenosis with normal LV function. There lies the problem. There dobutamine has no place at all altogether. Some articles had said Agastor's score of the aortic valve. Yeah. But I have started believing that if your vested work is more than around 200, and if your global strain is reduced to less than -15, these people should be operated, and they will do well. They will do well. Yeah.
That's an excellent message in a nutshell, sir. So there was one question from the audience. So somebody is asking, saying or commenting that fibrosis as diagnosed on NG, it takes MRI to do it and it's expensive. So can GLS be a substitute for that? That is the question.
Yeah, not exactly, but maybe Ponde can answer. Yeah.
No, I don't think GLS can be a substitute for fibrosis, because GLS is the efficiency of longitudinal fibers of the left ventricle going down, and ejection fraction is maintained at the cost of normal circumferential and radial strain. In fact, I had a patient of amyloid, 70% ejection fraction, GLS of -9, and circumferential strain exaggerated, radial strain normal. So this is how it is. So I don't think GLS can replace fibrosis. No, I don't think so.
Thank you, sir. We agree.
Thank you.
And we are running short of time now.
Yeah.
I think it's almost time for us to end. We have a limited time on Zoom, but it's been a fascinating discussion. I think it's a good beginning to our journal club. And we are very, very happy that so many participants could attend and all the faculty could be here. So Dr. Uday Jadhav was supposed to propose the vote of thanks, but he's unfortunately traveling and his flight schedules have been altered. So he's asked me to do it instead. So first and foremost, I would like to thank our generous host, Lupin. They have supported this program wholeheartedly, and they have been very cooperative right from the word go in contacting the participants, in contacting all PG students, in liaising between all the different faculty. And we are very grateful to Lupin, especially KD Rao and his team. And I think his other team member is also here online. So special thanks, Satish, to you and KD from all of us. I would like to thank our science cardiology department, our HOD, Dr. Nathani, because this time all our PGs or junior lecturers have presented, and we propose to have this kind of format in which in the future, one institute PGs can present turn by turn, so that it will be good for everybody to get that kind of experience. I'm especially grateful to all the faculty. Dr. Ajit sir is here right from the time we mentioned Journal Club. He just gave a green signal, said go ahead and do it. And he, Dr. Uday Jadhav, all the executive committee of the Mumbai CSI, Shetty sir is also here. So many people are here. And all the faculty who are today part of this program, I think the students will have found their experience to be very valuable. And as Yash sir told you, it's very important not to take anything at face value and to be critically analytic when you go through a journal article. And all of us have learned from that. And I also would like to thank the technical team for all their technical know-how and for ensuring a smooth flow of proceedings. And I think I should have let the president of the Mumbai CSI, Dr. Ajit Desai, have the last word before we call it a day. So please.
Thank you, Milind, and all the participants, particularly your postgraduate students who evaluated each of these topics, and the experts, the panel discussants, and all of you. Thank you very much for making this a grand success. This is the beginning, but we'll continue doing this journal club every 3 months, and we'll alternate with the in-person meeting every 6 weeks. So we'll alter all these things. And also to remind each one of the faculty members that we are going to have on the 17th of February, a meeting on Verisigwad at the Hotel Sofitel. So please join in. Thank you very much and good night.
Thank you, sir.